Welcome to our module on diarrhea. So in this video, I will talk about diarrhea, acute form and chronic form of diarrhea, and the different causes along with the workup. So let's start by definition of diarrhea. So acute diarrhea is characterized by acute onset of more than three bowel movements per day lasting less than 14 days and is often caused by infection, and these infections are usually viral infections. So that is acute diarrhea. Chronic diarrhea lasts more than 4 weeks and is often caused by underlying conditions such as inflammatory bowel disease or fat malabsorption. In between the two is persistent diarrhea, which lasts for more around 2 to 4 weeks of duration. So let's talk about acute diarrhea. So if a patient presents to you with uh, more than three bowel movements per day lasting less than 14 days, that means that the patient has acute diarrhea. So in addition, what you need to look for in the history is if the patient is having severe diarrhea. Now, this thing in red uh, means that the patient has severe illness. Usually, no stool testing for pathogens is required unless the patient is severely ill, and the severely ill patients, meaning hemodynamically unstable, hypovolemia, severe abdominal pain, blood or mucus in stool, fever more than 100, and high-risk patients as in immunocompromised. So these patients must be taken seriously, and extensive workup is needed. However, in any patient who presents with acute diarrhea, you do stool culture, stool analysis, wherein you look for fecal leukocytes. If the patient has no fecal leukocytes, then that's non-inflammatory diarrhea, and that suggests a small bowel source or colon but without mucosal injury. If there is fecal leukocytes, that means it's an inflammatory diarrhea, meaning that there is a bug that may be causing invasive damage to the colon. Okay, such bugs may be Shigella, Salmonella, Campylobacter, or Yersinia, or toxins such as C. diff toxin or enterohemorrhagic E. coli, E. coli 015787, or it may be inflammatory bowel disease. So these means that the patient may have inflammatory diarrhea. Okay, so what you need to do is stool studies, which include stool fat, culture, ova and parasite, electrolytes, and pH. And a low pH generally means that the patient may have carbohydrate malabsorption, as in osmotic diarrhea. And as I said, leukocyte presence suggests enteroinvasive infection. A pH less than 5.5 indicates viral illness and can also indicate lactase deficiency. Okay? Uh, then enzyme immunoassay for rotavirus and adenovirus antigen if you're suspecting so, and latex agglutination assay for rotavirus. Rotavirus is very common in unvaccinated pediatric age group. C. diff toxins. This is when if you have a suspicion for such. But basically, what you really need is the initial test would be stool analysis for culture and ova parasites. And in fact, you may also need electrolytes and pH of the stool. Okay? So why do you need electrolyte and pH? Because you want to know if this is an osmotic diarrhea or secretory diarrhea. So basically, you wanna find out the osmotic gap. So osmotic gap is 290 minus the twice sodium plus twice potassium, the electrolytes found in stool. So if you have an osmotic gap more than 50, that means it's osmotic diarrhea, or an osmotic gap less than 50, secretory diarrhea. So what are the causes of osmotic diarrhea? Osmotic diarrhea may be due to lactose intolerance, sorbitol, or lactulose. Versus secretory diarrhea, these may be infectious causes like cholera or O15H57, or VIPomas, these are neuroendocrine tumors, or maybe bile acid malabsorption. An additional one is microscopic colitis. Microscopic colitis is a form of a secretory diarrhea. It's a chronic inflammatory diarrhea of the colon, which results in a watery, non-bloody secretory diarrhea, and the colon often is normal on colonoscopy. However, why is it called microscopic? Because the microscopic findings are abnormal. So there are two histologic subtypes of microscopic colitis. One is collagenous and lymphocytic. So collagenous colitis is deposition of collagen subepithelial, while lymphocytic colitis is intraepithelial lymphocytes. The basic treatment for this is antidiarrheal drugs like loperamide, or you may also add budesonide or oral glucocorticoids. So this was about microscopic colitis, and additionally, um, we will talk about the chronic diarrhea. So chronic diarrhea may be fatty, may be inflammatory, or may be watery. So watery diarrhea, as I said earlier, may be secretory or osmotic. So you want to do a fecal electrolytes. Fecal electrolytes is important because we want to find out if it is find out the osmotic gap, if it is osmotic diarrhea or secretory diarrhea, right? Also, you need to do stool pH and reducing substances. Osmotic diarrhea essentially gets better on fasting, okay? Versus secretory does not get better with fasting, okay? So, that was about watery diarrhea. How about the fatty malabsorption? In fatty malabsorption, patient will actually present to you saying that I have very greasy stools and it's very difficult to flush. So that is indicating a fatty malabsorption. So in that case, you will do a fecal fat test and fecal elastase test. Fecal elastase is important in diagnosis of chronic pancreatitis because this goes low in chronic pancreatitis versus other forms of chronic diarrhea. All right, and fecal fat testing, you would do serum black stain of stools with stains and detect fat, or you may do the most sensitive 72-hour fecal fat test. So those are the tests required for fatty malabsorption. Versus the inflammatory diarrhea, you need to do the white blood cell count, stool culture, and fecal calprotectin, which is released. This calprotectin is released from the white blood cells. All right. So this is, in a nutshell, a very brief introduction to chronic diarrhea. Now let's get into a focused workup. Okay. So focused workup on osmotic diarrhea. Osmotic diarrhea, the history would be watery bowel movements with modest volume, which is relieved by fasting and is associated with specific foods or medicines. All right, so this goes a lot with, lactulose or sorbitol. Maybe there is some consumption of osmotic substances which is resulting in diarrhea. So there is always an association with specific food or medications in case of osmotic form of chronic diarrhea. Okay, and is relatively relieved by fasting versus secretory. Okay, which is not relieved by fasting. And in examination, the osmotic diarrhea is normal. Um, and there's no specific lab associated with osmotic diarrhea. So what you need to consider, however, is to maintain a food diary and a trial avoiding certain foods or medications. And consider diagnostic fast. All right, you ask a patient to fast, and if the patient improves, that means the patient is consuming some sort of osmotic substances, which is resulting in diarrhea. Okay, and then you may also do the stool osmotic gap, which is with the help of stool electrolytes and um, calculating the osmotic gap. Here, if it is more than 50, as in more than 1, which is 125 milliosmoles per kg, this is indicative of osmotic diarrhea. Some of the examples, as we have said earlier, may be lactulose intolerance, or maybe lactose intolerance, or maybe um, laxative abuse and sorbitol use. So, lactose hydrogen breath test if you suspect lactose intolerance. Colonoscopy is generally not needed, but if performed, you may see melanosis coli in laxative abuse. It's a very high yield question, very commonly asked in the SEP2 exam. So, a patient on laxative abuse may show a melanosis coli. All right, so here there's no treatment required. It gets better on its own when you stop the laxative use. And then secretory diarrhea. This also causes watery bowel motions, high volume, not relieved by fasting, and essentially occurs at night. Nocturnal bowel movements, particularly common. Okay, so there's no particular exam or specific labs. Again, you do a stool osmotic gap test, which will be less than 50, and you need to consider certain specific hormone testing like VIPomas, gastrinomas. These can cause secretory diarrhea. And if the patient has fever, all right, you need to rule out E. coli, enterohemorrhagic E. coli, or um, um, enterohemorrhagic E. coli from the diagnosis, right? And then moving on to malabsorptive syndromes. Malabsorption, as I said earlier, the patient may present to you with greasy, foul-smelling bowel movements, with weight loss. Symptoms of nutrient deficiency may be present. So usually you need to look for vitamin A, D, E, and K deficiencies in patients who present with fat malabsorption. So an exam usually is normal, and in non-specific symptom lab findings, you may happen to see, uh, anemia, iron deficiency anemia, vitamin D deficiency, or calcium deficiency. Okay, so assessment of stool fat, as we said earlier, you need to do a student a stain of stools along with 72-hour stool collection on 100-gram of fat per day diet. All right, more than 7 grams of fat in stool is diagnostic. Okay, and you may or may not do endoscopic tests. All right, depends on the diagnosis. Um, Additionally, abdominal imaging is sometimes needed. And you, as I said, you need to do certain serologic testing for celiac and chronic pancreatitis. We will talk about the malabsorptive syndromes in detail in another topic. And then hypermobility, nocturnal bowel motions, particularly uncommon, and patients may have weight loss. Uh, And one of the cause of hypermotility may be irritable bowel syndrome. And in irritable bowel syndrome, weight loss is atypical. If the patient has weight loss and irritable bowel disease, then it must be worked up further. Okay. Often, relationship between emotional, environmental stresses, and severity of the symptoms is common. Now, in IBS or in irritable bowel syndrome, the findings are normal, and sometimes hyperthyroidism may also cause hypermotility, nocturnal bowel motions. So you need to rule out hyperthyroidism as well. Additional features also must be looked forth. And you need to do the TSH levels and consider testing for celiac disease as well. Inflammatory bowel disease or inflammatory cause of bowel motions. These may present with bloody or mucus-like bowel motions with fever, abdominal pain, and sometimes joint and skin symptoms, which may suggest inflammatory bowel disease. Now, the signs of systemic inflammation are often present during acute flare, and Guac positive stools uh, because of internal bleeding. Anal fissure and or fistula suggests inflammatory bowel disease. In these inflammatory cause of diarrhea, there will be elevated white blood cells, ESR, and CRP. So you need to do a colonoscopy, fecal calprotectin, stool testing for C. diff, particularly if recent hospitalization or antibiotics. So let's talk about more in detail about C. difficile infection. So C. diff infection, patients present with uh, excessive diarrhea. And If there is a history of recent hospitalization or use of antibiotics, especially clindamycin or the broad spectrum penicillins, and in fact, chronic use of proton pump inhibitors can also cause C. diff infection. So patients present with severe watery diarrhea, and sometimes it may turn bloody as well. So if you suspect if C. diff infection, uh, you need to test for toxins. Okay, you're not going to do cultures, but what is important in case of C. diff infection diagnosis is the toxins. All right, so the bacteria releases two toxins, toxin A and toxin B. Toxin A is called the enterotoxin, which is uh, responsible for watery diarrhea, and toxin B is cytoskeleton toxin, which causes cell necrosis and fibrin deposition. Now, these two toxins bind to the GI cells and are internalized, and that results in cytoskeleton loss in the GI cells, and that results in a pseudomembrane, and therefore this disease is called pseudomembranous colitis. It's classified into three: non-severe, severe, and fulminant. Severe is when white blood cell count is less than, sorry, non-severe is when white blood cell count is less than 15K. Creatinine is less than 1.5 mg per dl. All right. The way you treat non-severe cases is with oral vancomycin or fidaxomicin. All right. Severe, however, white blood cell count will be more than 15K, creatinine more than 1.5 mg per dl. The treatment here would be oral vancomycin or fidaxomicin, or sometimes stool transplant. Versus fulminant. Fulminant causes hypotension, shock, ileus, elevated lactate. Here you may treat with oral vancomycin plus metronidazole, as it's more likely IV, all right? And then surgery, oral vancomycin plus IV metronidazole. The surgery is essential to remove the um, infected part of the colon, so colectomy is essential as well. So that was about C. diff infection. Now, one thing I want to highlight about is irritable bowel disease syndrome, and it's very commonly tested. Uh, Irritable bowel syndrome is diagnosed based on Rome 4 criteria. It's very important to know that. So, what is Rome 4 criteria? It is recurrent abdominal pain, discomfort for more than or equal to 1 day per week for past 3 months. In addition, you must have more than or equal to two of the following. What? It is related to defecation, improves or worsen, change in stool frequency, and change in stool form. All right, more than or equal to two of these three, along with abdominal pain for more than or equal to 1 day per week for past 3 months. All right, so that is Rome 4 criteria. So alarming features, and you don't usually see this in irritable bowel syndrome. If these alarming features are present, you need to work up further for other causes of diarrhea or bowel disorder. Okay, so older age of onset, more than or equal to 50, gastrointestinal bleeding, nocturnal diarrhea, worsening pain, unintended weight loss, iron deficiency anemia, elevated C-reactive protein, positive fecal lactoferrin or calprotectin, family history of early colon disease, cancer, or inflammatory bowel disease. And especially in nocturnal diarrhea, if you previously labeled the patient as irritable bowel syndrome, however, this patient presents to you with nocturnal diarrhea, this suggests secretory diarrhea. Okay, nocturnal diarrhea, as we have discussed earlier about the secretory diarrheas, they present with nocturnal diarrhea. Unlike osmotic causes of diarrhea, right? Patients with secretory diarrhea develop symptoms while fasting, often in the middle of the night, and etiologies include chronic infections, microscopic colitis, bile salt diarrhea, or a hormone secreting tumor like gastrinoma, VIPomas. Therefore, appropriate lab studies and colonoscopy must be considered in patients who present with such symptoms in irritable bowel syndrome. Okay, so this was all about diarrhea, which covered both chronic and acute diarrhea and some of the causes of each. Now, in the next video, I'll talk about different malabsorption syndromes. Please like the video and subscribe to my channel. See you there. Thanks.